Good evening. My name is Beth Emery. I'm a past president of the Alamo Breast Cancer Foundation and ABCF's alternate to the National Breast Cancer Coalition Board. Last year, I was director of the Alamo Advocate Program. Welcome to the 28th annual Alamo Advocate Program. This program was started in partnership with the organizers of the San Antonio Breast Cancer Symposium to enhance the educational and networking opportunities of patient advocates at SABCS. We're pleased to have all of you here in person and virtually. And this year we have one of the largest classes of Alamo scholars in our history, 36 scholars, of which 30 are sponsored by Alamo, 4 by Teresa's Research Fund, and 2 by Metastatic Breast Cancer Alliance. The scholars come from 16 states and Puerto Rico and 8 countries. And we also have 7 incredible volunteer advocates who are serving as scholar mentors. This year's Alamo Advocate Program is dedicated to the woman who founded both ABCF and the Alamo Advocate Program, Dale Eastman, my mentor. We are delighted that San Antonio Breast Cancer Symposium has dedicated this entire week to Dale, and you will see more on that in the general session. Now, Judy Perkins will present a moment of silence. This is something that was started by National Breast Cancer Coalition, and we're proud to do it to honor advocates who have lost their fight with breast cancer.
Marlena Murphy was diagnosed with triple-negative breast cancer in 2018 and with metastatic breast cancer in 2022. Advocacy came naturally to Marlena. After her first diagnosis, she was connected with other survivors and volunteered as a patient advocate with My Style Matters. She went on to participate with GRASP as a mentor and later worked as program manager for the organization. She was actively involved in many other organizations, including working with National Coalition for Cancer Survivorship and serving on the FASCO Clinical Trials Access and Inclusion Task Force. As a result of her diagnosis and desire to help people, Marlena returned to academia to pursue a master's degree in clinical mental health counseling. Following her degree, she began providing clinical mental health counseling at Turning Point Breast Cancer Rehabilitation for patients and survivors of breast cancer, roles she knew all too well. Marlena was actively involved in research advocacy and participated as a peer reviewer for the Department of Defense Breast Cancer Research Program. Wanting to increase her knowledge about the science of breast cancer, Marlena attended and graduated from Project LEAD in 2023. Marlena passed away at the age of 46 on July 4th, 2024. Please join me in a moment of silence to remember Marlena. Thank you.
Thank you, Judy. I'm going to introduce Mary Jimenez, who's the director of the Alamo Advocate Program this year, and she will introduce the panel. While they're coming up and getting settled, I want to acknowledge our sponsors who make this program possible. Their logos are shown on the slide that's about to go up. Our premier sponsors are Genentech, Pfizer, Menarini Stemline, Lilly, Novartis, and Cybermedia Productions. Collaborating sponsors are Daiichi Sankyo, Merck, AstraZeneca, and Natera, and our contributing sponsor is Exact Sciences. Mary, take it over.
At this time, I can have my panelists join me on stage. Thank you very much, Beth. As Beth said, I'm the director for the Alamo Advocate Program. I serve on the San Antonio Breast Cancer Planning Committee, and I'm also the chair for the UT Mays Community Outreach and Engagement. This evening, we're going to have 4 mentors. Each are going to spend 10 minutes highlighting what caught their attention in today's sessions. After that, we'll open the floor for questions, and it's my honor to introduce the speakers. Dr. Mariana Chavez McGregor is a tenured professor in the Health Services Research Department, where she serves as interim Chief and Breast Oncology Department at MD Anderson. Her research focuses on outcomes in cancer care delivery. She serves as the Executive Officer for the International Affairs at SWOG, where she leads the Latin America Initiative. Dr. Bora Lim is a tenured associate professor at MD Anderson. She is currently serving as a translational lead for both Breast Medical Oncology Department and Morgan Welch IBC Research and Clinical Program. She focuses on addressing the challenges of metastatic and inflammatory breast cancer. Dr. Mazo Canola, who was previously scheduled for Thursday, is greeting us with her presence today, just with conflict schedules, and we are proud to have her. Her research work includes evaluations of clinical trial participation of Hispanic patients, health disparities during the COVID pandemic, as well as genomic and germline differences in Latinas with breast cancer. She currently serves as the medical director for hematology and medical oncology for the University Hospital. Unfortunately, we could not have Dr. Maria Theodula. She had medical emergency, and this is why we have a schedule change, and also Steffi Osterauer. So we are going to begin our program now. We'll start with you, Dr. Mariana Chavez. Do you want to share a little bit of today's sessions and what you thought was most intriguing and exciting?
Sure. So first of all, good evening, everybody. There's, that wonderful introduction, but I want to tell you a little bit more about me and what makes for me very special to be here today. I'm not saying anything that it's confidential, since she was pretty open sharing this, but I was Dale's physician the last years of her life. I was very proud to call her my patient. I think she was very proud to call me her doctor. And throughout those, challenging at times last years, we of course got, many, many encounters together. And the love that she had for all of you and for the power of this community, it's something that really inspired me. So for me, it's very meaningful to be here. I guess that means that every single year you guys can take advantage of me and invite me, and I will always say yes. I got a last minute invitation to be here tomorrow, so again, I say yes. But it's because it really means a lot, and I get to see it like firsthand and learn a lot of the extraordinary work that you guys do. So I know you guys did not invite me to talk about that, but anyway, I could not talk about her and how important I know this meeting is. So regarding the sessions, as you know, this is the most important, largest breast cancer meeting in the world, and we're just getting started. So there's maybe not that much necessarily to talk about in terms of breakthroughs, but I can tell you what I found incredible today. As you know, mostly we had educational sessions. There's mini orals going on right now, but I attended 2 educational sessions. The first one was called Open Bar and All You Can Eat. And the other one was about hormone replacement therapy and management of symptoms associated with menopause. And I really think it's extraordinary that we're having these conversations. I know that there were a lot of patients and advocates in those sessions, but there were also a lot of physicians. And I think we were there because we know those things matter to you, right? Like, I get asked every week in clinic about diet, about alcohol, about exercise, and also we get to hear about the symptoms of the treatment that we, cause, all of you, and how we really need to partner in a better way with you all to understand, how to manage things, how to acknowledge the gaps in evidence. But I think it was just fascinating. I learned a lot. I think I will continue to encourage organizations like San Antonio to talk about these very, very relevant topics, because the reality is that we don't learn a lot about that during our training. We just don't. And I think, part of the message is this partnership where you can challenge us, right? I know sometimes we may not have enough time in the clinic to talk about, hot flashes and vaginal dryness in the setting of, disease progression. But these things still matter. And I think those, if you did not attend, go listen to the recordings. I thought they were truly extraordinary. So I guess I will stop there. And
So that's great. Lifestyle changes do matter, and these do play a difference that you've seen. There's data that shows diet and exercise decreases the risk of reoccurrence. And so this is where we're heading. This has always been a part, and I think we knew it, but now to see it in the data and the literature now catching up is speaking to the research that's being produced now to validate that. So, Dr. Lim, do you want to add?
Yeah, this is one of my favorite sessions during the San Antonio. I'm a translational person, meaning I do a lot of drug development. So my goal is there could be a lot of wonderful science happening in different laboratories, but if it doesn't help my patients today, who's even as we speak, I have 2 patients in the hospital. So I'm pretty worried that, they may not be there when I go back. So to me, the most important thing is let's bring the science today into the clinic so we can actually save the patients today. So for us to do that, we have to have a lot of meetings, right? So honestly, today, as soon as I hit the San Antonio, I've been in the meeting room all day, until I came here and right in front of the front door here. So I was gonna attend some of the liquid biopsy sessions, but I wasn't able to. But then I saw all these cool topics of the energy metabolism. So although I'm coming clean that I couldn't really attend any of the sessions, but honestly, it's very exciting for me to see even the topics of the liquid biopsy. And then I know that when we are talking about the liquid biopsy, everybody's shaking your heads, and a lot of you are thinking about, so circulating tumor DNA. But what I would like to potentially discuss today is there are liquid biopsies beyond circulating tumor DNA. I think in next few years, first of all, it's very exciting to even learn that circulating tumor DNA is discussed in the clinical setting, that it's no longer, some type of concept, it's there, but we may not be able to reach. I think a lot of us are finally implementing how we're gonna do this, how often, how much, what type, do we change in the treatment. But more excitingly, that beyond that, many of even this lifestyle modifications and so on and so forth, human life changes all the time. I don't think I'm the same person who I was 3 years ago that, or 4 years ago. I was able to do shots all day and then go do my session at 7 a.m. So if the human changes, of course the cancer will change too. So, biopsy, tissue-based, tissue has a one snapshot compared to liquid biopsy can give you more overall emerging changes of what's happening in your tumor. And that could even be involving immunotherapy, immunokines, immune cells. And so when we are doing this life modification, treatment changes, can we actually detect them before something that we can, see in the tissue or imaging? So that's my topic. So hopefully we can have some of the discussion today. So, yep, but I come clean, no session. Sorry.
Dr. Mazo, Canola, do you want to?
So I'll be next. So it's really great to be here. I know a lot of you. Obviously, I'm local. I didn't have to get in a plane. It was just a quick 20-minute drive from home. But today I had the opportunity to attend 2 sessions, and I'm going to piggyback on what I'm going to say because I'm Colombian, and I'm going to make emphasis in one of the things that was mentioned in the first educational session that I attended, which is the young breast cancer. It was chaired by Dr. Patrick. So I was really taken away when they were talking about differences in ethnicity, with Hispanics and Blacks having higher incidence of younger cancer. So that was one of the things that in a way, captivated my attention because I live and breathe, and my mission in life to me is to work in these health disparities. So my conclusion after hearing them is that we have learned a lot, but we still have a lot of work to do. And I think you as advocates, when we hear the science, and I saw some of you attend this session, You really need to get this information to use your power to educate. You know, patients listen to you, patients trust you. So it's good that you get informed in this, you know, in this session so you can spread the knowledge. So it was a very, you know, provoking session in the sense that we talk about a lot of things, and we talk a lot about how young breast cancer is on the rise, and we don't have a clear explanation why. I mean, I cannot tell you how many times I get a patient in clinic, and since I'm Colombian and I speak much better Spanish than English, you know, these patients that are, you know, don't speak English, they tell me, you know, I was telling my doctor for months and months that I had something wrong with my breast, but I was told I was too young to have breast cancer. So this is, you know, we have scientific information that shows you that this is a reality, and you have the power to educate. The second session that I attended was the educational session on post-CDK4/6 inhibitors. It was also a very interesting session. We did a very nice review discussing the current treatments that we have available, and we were able to see how much we have moved the needle in the sense that, you know, those curves, they start looking better and better when we compare the curves for the studies that we have right now compared to the studies that we have perhaps, you know, 5 years ago, 8 years ago. You can see the progress that we have made. But I'm gonna make a point in something that caught my eye. So at the end, Abigail Johnson, who is a patient advocate, she started her presentation and she put her disclosures. And her disclosures were her 2 kids. So it kind of, you know, in a way, it brought me back and saying, oh my gosh, you know, I tell my patients, yes, I'm gonna push in this drug, but don't worry, you know, grade 3 diarrhea. You know, perhaps you know, in my head I'm thinking, well, the percentage of grade 3 diarrhea was low when we talk about this clinical trial, when we saw the results. But for that woman, that's going to the bathroom more than 7 times a day. So it kind of, you know, brought it to me that we really need your input when we design these clinical trials from the get-go. Yeah, and Abigail said that in her presentation. I think having the patient perspective and having you kind of pitch in on what your experience, because, you know, I read the clinical trial. Perhaps I memorize side effects. I know that I have to be careful with bradycardia or with neutropenia or with stomatitis, but I've never been in your shoes. I don't know. So to me, that was the biggest lesson. You know, having an advocate in an SABCS podium today, making it real was quite an eye-opening for me today.
I would say that honestly, we should have had 4 advocates up here talking, because it'd be interesting to get you in the audience, your perspective, right? Patient advocates living through treatment, and then looking at what modifications and things you do in your life, because it really is a lot. You're like the doctor at home, right? You've got to manage that through. And so it'd be nice. So I'm going to open up. We've got 2 mics, and we're going to ask that you can come up to the mic, state your organization and your name first, and then just ask. You can ask the questions, and any of the panelists can answer. If you have any questions out there in the audience, somebody want to step up? Debbie, yay.
We know you're not shy.
No. We can tell her by her first name. Debbie, yay.
My name is Debbie. I volunteer with FORCE and many other organizations, but I'm really interested in ctDNA. And when I attended that session.
Oh.
Yeah, but they were talking a lot about lung cancer. All the examples were lung cancer, and another one that it was cerebrospinal fluid, that they would take it off. So they were not related to breast cancer. So can you make that connection, and whether for us to know whether or not it works, and how often we have to do the ctDNA? That would be really helpful. Thank you.
So should I?
Sure.
I mean, so when you think about how this cancer is, so cancer is it's, you know, like your own cell, and then their goal is to survive no matter what, to the point that it will actually invade your own host or your parents. You know what I mean? Like, so to me, like, it's one of the bad guys showing, but the Bible, it just doesn't know when to stop. So when you understand how these cancer cells behave, there's a lot of similarity regardless of where your organ origin is coming from. However, when you think about the breast or prostate cancer, we have a very unique biological barriers. And so when you think about, for example, colon cancer or stomach cancer, lung cancer lives in that environment where there's a lot of like highly vascular, it's like a big highway, it's kind of New York, it's open to like a blood circulations, and then the lung, cancer forms, and then it goes to the lymph nodes and propagate. Colon cancer, it kind of starts from the mucosa and then it goes to the lymph node around it. Breast cancer is very unique, that it is one of those organs that just like the skin, so we think the melanoma and breast cancer, and probably similar to prostate cancer, when the cancer happens in that very fatty organ, that actually started to have the immune activation that has to be communicated either through lymphatic channels or like in the surrounding, but lymphatic channel is much more higher. And so when you see how this breast cancer might behave, it's very different than with some other cancers. And then there's a different degree of like how the ctDNA can actually be shed. So historically, if you think about the kidney cancer has been known to have a very low degree of the shedding of the circulating tumor DNA into the system, potentially because kidney is so good at like filtering things out, that has to be recircled back into the blood system and then has to be shared in the blood. When you think about the breast cancer, it really depends on your degree. So ER positive cancer is very different from the triple negative breast cancer. But when you think about the principle of the ctDNA, there shouldn't be any too much of the big differences. What we will see in the colon cancer, breast cancer, what truly could be different is that once we have that information of the ctDNA, how we're going to use that information too. So for example, the colon cancer, let's say if the BRAF mutated, I'm not a colon cancer expert, so if there's any, I apologize, but, or immunotherapy does work in the, the MSI high populations. So you already do have a little bit less kind of confound interventions that you can have in your toolbox and then put it out. The challenge of the breast cancer that we face today in the ctDNA is that, let's say there's estrogen receptor positive breast cancer patient stage 3, we follow them, ctDNA positive, we confirm there has not been the imaging-based recurrence just yet. So then the question is, can my intervention today make a difference for that patient's life for the next 20 years? And so really the challenge becomes that, is that one intervention applied to all? Is that even the right intervention? Do we need to capture that intervention based on your mutation data, like the ESR1, like a CERN6 was trying to do? So breast cancer is such a heterogeneous disease that addressing that each area will take a little bit of time. But I can tell you, even today, let's say I was sitting there, trying to do my prep for the meeting, and I can have 6 different pockets of people that I'm such an ADD, I listen to all of their conversation, and 4 out of 6, they were talking about ctDNA data. So what I can tell you is the breast cancer has awakened. The force has been awakened, and then I think that it's gonna be discussed more, and hopefully we'll have the intervention actually being presented in this meeting. So the cadence, frequency, how much we have to do it, will be also hopefully streamlined based on what we know about the biology.
And if I may add, Barbara, because I think this is a super important topic. I cannot think about a week that I don't have one of my patients asking me about circulating tumor DNA. So I think the reality is that these are extraordinary technologies that are part of our reality now. There's a lot of heterogeneity in all these tests. Some are better than others. We're learning a lot about them. Other cancer types are leading the way on how they're actually used in clinical practice. And as of today, and some of my colleagues here could potentially disagree with me, but as of today, the routine use of circulating tumor DNA for monitoring or detection, it's not part of any guidelines. So the how, the when, the what often, the what are we gonna do with that information, we still don't know. I think it's going to be the way of the future, and I really hope that we can use that information to tell you about prognosis, to select patients that we can optimize treatment, right? Who needs more treatment, who doesn't, and there's extraordinary teams all over the world working on this. There are clinical trials that right now are incorporating circulating tumor DNA, but the reality is that we just don't know.
I agree, 100%. I don't do it in my clinical practice either, as a way to monitor disease. That's not in the guidelines just yet.
Yeah, that's why we need to work hard to make the changes. So like today, we can sleep because we wanted to make that become a reality tomorrow. So hopefully we'll get there soon.
Yes, go ahead.
So I sat in on the all-you-can-eat session. I'm Roberta Gelb. I'm with Share Cancer Support in New York, and I'm a member of MBCC, and I had the opportunity to participate in the MBCC Policy Academy this year. And so I sat in there and I listened to this discussion about alcohol and breast cancer. And I thought about the session I was at, I think it was MBCC. I was trying to figure out when it was, probably about 15 years ago, when we heard about the link between alcohol and breast cancer. And every year, when I come back from a conference and I post or talk to people about the link, they say to me, I never heard that. So we have cigarettes. You have a warning label on cigarettes that cigarettes cause lung cancer. Why is it? I mean, is it that the alcohol lobbyists are so well funded that they have managed to keep this out of the public's knowledge? And if so, what ideas do you all have as to how to get this out there to make sure people know about this link?
I think it's something that is emerging as a substance that will cause DNA damage, and that definitely increases the risk of cancer. But I think the limitation that we have in our society is that alcohol is very socially acceptable, right? Like perhaps cigarettes were some time ago. I think as we have more research coming to us that makes this more, that makes this connection in a stronger way. My speculation, and maybe perhaps Dr. Sanchez-Madero, Dr. Lim, you can, piggyback on this, is that we will get to that point. But I think the main limitation is the fact that it's something that has been very, socially accepted. I don't know.
I think part of the movement, it's, I agree, it's towards, having the conversation. Alcohol as a carcinogen, it's part of the general surgeon's report. That's pretty novel. I think part of the reason behind all of this, in addition of the reasons that you mentioned, probably has to do with some of the inconsistencies in some of the data or the types of studies that have been done historically, and some of the confounding biases that have been in these observational studies. I think what it's clear is that binge drinking is really associated with breast cancer, and I think we as doctors also have to be educated as that, right? So we can discuss with our patients and also inform them on the magnitude of the risk. And it was discussed over there, right? Does that mean that you cannot have, if you want one glass of wine, if you decide that that's something that you want to do? It's just about being informed, I think, about the risk of the benefits and the interaction. I was there and I actually asked about, for example, how with all this data about the increased risk of alcohol, right? We know there are countries in the world where drinking wine, particularly red wine, it's, part of the standard meal, right? We can think about Italy, Portugal, France, and Spain, et cetera, et cetera. There's no more breast cancer in women there. Breast cancer patients with breast cancer, they don't have worse outcomes. They don't have more cancer come back. So why is it, if drinking is so bad? Is it that at the end, it's a little bit of everything? It's the amount, it's the lack of obesity, it's a better diet, it's the exercise, right? It's maybe, that we need to talk about it all, right? Better lifestyle in general, and tools for each one of us as patients, as physicians, as women, as human beings, right? Make better or at least informed choices.
I'm going to go now. before. So a couple of things. I am a physician, and I went through breast cancer and stage 3C, triple negative, pleomorphic, invasive lobular, so really rare. And I did suffer all the side effects. So I know chemo brain. I have neuropathy. I live it. It took away my career. So when you talked about hoping never to walk in our shoes, I hope you never have to as well. When you talk about young people, I'm a medical advocate now. I have 2 young women, 35, Hispanic, non-Spanish speaking, diagnosed with stage 4. So the things you're talking about are very, very real out there. And when you said something about circulating tumor DNA being very hopeful, I'm thinking, is there a way for some research to link the changes in circulating tumor RNA to exercise, to alcohol, to meditation, to Reiki, to yoga, to all the things that I believe are part of the comprehensive way to live and stay alive? I don't think I would be here without that whole picture. And so when I saw that, the presentation on the circulating tumor RNA, which can catch that, right? It can catch the microenvironment changes that can occur. Is that not true? Or am I reading it wrong? Is there a way that we might actually be empowering oncology to look at how to be holistic about care and not just focus on drugs?
Yeah, no, I mean, that's a great, great point. So actually, I am working with a few collaborators on trying to get that circulating cell-free RNA into the picture. But actually, the angle of the RNA is mainly for the transcriptomic, meaning like, you know how like the DNA is like a flour powder, and then the RNA is like the pizza dough, and then the protein is actually the pizza that you kind of have the final products. So if you do have information about the pizza dough, like how consistent and blah, 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 you can actually have a lot of information about the therapeutic choice and the differences. However, the information you're talking about the exercise and changes actually should be captured in a more comprehensive way, like things like an epigenetic changes, like a methylation, for example. Yeah. So the thing is, there are many companies as well as the academic researchers are working on this methylation detected either in tissue, in the blood. But as you can imagine, humans are so complex that if one were to develop an assay trying to be able to deter difference between the normal and not normal, and then how the cancer behaves, you have to know what the normal is. And so methylation actually struggles from even trying to identify what the normal is. If I were to test you all of your methylations today, I am sure we'll struggle with the data and trying to figure out. So, but we have been closer than ever than before. But the little bit on the easier goal, honestly, is that nowadays that when we spin the blood, there's a layer of the top coat, we call it buffy coat. So in the immunology, in the biology, back in the days, I'm sure you heard about the cell layers and blah, blah, blah. So in that buffy coat, we could actually capture a lot of information about your immune cells. And so, for example, my patients who are like inflammatory breast cancer patients, many of those patients who expresses that exhausted immune cell response, like who would have had that immune response profile like 5 years after it, like somebody's metastatic and has been getting the 5 years of treatment, would have developed this. My inflammatory breast cancer patients, many of them would have had the signature after 3 months. And so we are actually able to capture some of the signature. One of our colleagues are trying to implement an exercise program where before they get the immunotherapy, we send them to the exercise. And then we actually trying to see what happens in their B cells and T cells. And so maybe we can even start from there. But then with the methylations and understanding the whole body, I think it's gonna be mind-boggling, but hopefully we'll be able to actually get there too.
But I think to your point, there are other type of interventions that can help, or therapeutics in very profound ways, and we just need to make sure that we study them.
Yeah.
My name is Sharon Anderson, one of the board of directors of MetaViber. Also do work with Teresa's Research Foundation and ABC with Dr. Bora Lim. My ADHD is kicking in. I've been staying up too long. One of my things is about the side effects, and I spoke about that earlier, about bridging that communication, that gap with side effects. A lot of patients may not explain to their physicians what's going on with them. Sometimes those little things that's going on with you could mean something big for you. One of my side effects was neuropathy. And let me tell you, and Bora could, account for that. I've been on the cane. I've been losing my balance. I've been falling. I've been tripping. Spoke to my oncologist, and we did things, step by step to figure out what's causing the neuropathy. And actually, that bothered me more than my initial diagnosis. I was diagnosed in 2013 with stage 4 inflammatory breast cancer and de novo metastatic. I wasn't as bothered about that diagnosis than I was about losing mobility. I don't know why, but in my head, that was more devastating to me, to be able to walk. I was a past athlete in my day, so in your head, you always think you're an athlete. I don't care how big you get. But losing my mobility was a struggle for me mentally. This year has been kind of bad for me because of the side effect of that. But the simple conversation with my oncologist and figuring out what it is, taking things one by one, changing medications, and going through the process. Sometimes just communicate. Say something to your oncologist. Don't suffer, and because there's some things they can do about what's going on with you, and some things they may not. But I'm here now. I brought my cane, but I don't need it. If I need it, I use it. But I'm in a better place because of it too, because it limits what you can do sometimes, if you're just falling because your legs just give out. But what do y'all I just want to know, if as physicians, is there anything you can think of that would help when you're sitting there with your patient? You may see them struggling or maybe walking funny a little differently, helping them, because some patients are shy or they don't know to ask these questions, and you may see something going on with them. Can we move that along a little more? Because I see people, they talk to us online and tell us things, and we're like, tell your oncologist. And a lot of people sit in there and they're intimidated sometimes, or they're not sure if it has anything to do with their cancer diagnosis. And but I always refer them back. Ask your oncologist, let them know, because something small to you may be something else. It's better to know than to not, to have something worse happen.
I believe communication is key. I think we have to be very intentional, or I try to be very intentional in the way that I interact with my patients. And I invite the patient to be the same way with me. Maybe just as a personality thing. I'm Latina, bubbly, huggy, touchy, loud. Anyway, but I think being intentional and keeping that communication going and working together. I tell my patients, this is a partnership. You're the boss at the end of the day, because I'm here to put the cards on the table to, inform you, to tell you about these treatments, the potential side effects. But this is a two-way street. I tell you, but you gotta tell me. You have to trust me. I think that relationship has to be a good fit. And I think the patient has to feel comfortable with the person that is in charge of keeping them healthy. So you need to ask the questions. I think, you need to come out of your shell and be vocal and advocate for you. I've heard from patients that they feel like their oncologists, sometimes they think that they're gonna get mad or they're gonna get offended, yes. But this is your life. Mm-hmm. So you really need to, be vocal and speak up.
Thank you.
Yeah, I don't know.
I totally agree with you. I mean, something that unfortunately it's a reality, and I wish it was not this way, but we are still struggling managing symptoms. I mean, that it's just the reality. I mean, there's so many conditions that are associated with neuropathy, and we still don't have a solution for it. I mean, treatment-related fatigue, it's a reality, and we don't have, we can think about interventions like exercise and, other things that do help, but it takes time, so we also need your patience. We need sometimes to experiment with different things. Let's try this, let's give it a shot. Sometimes we need to get other providers involved that can help us, that may have more expertise. Palliative care experts, symptom control experts can be extraordinary. Sometimes for you, being open to try things a little outside the box, it's also going to be important. Acupuncture, you were mentioning like yoga, like other methods that really, you need to be open to it. And then the reality of the healthcare system that we're in. If some of us are scheduled to see 25 patients, sometimes we just don't have the bandwidth, and we need to find ways to give you that space. Something that I've heard that has helped in some of my encounters and with some of my colleagues, it's just nice if we get a heads up, right? I have some of my patients that have sent me my chart messages like, hey, this is really bothering me. When I see you next week, I really need to talk to you about this. And it's really nice because it sets the frame of the conversation, and it can be that day, we're focusing on it. But that prepares me. So maybe that's something that could work to let us know what matters to you. Also, it can be easier. Sexual concerns, I think that sometimes some patients feel more inclined to send a message about it, and then it's our responsibility then to bring it up so we can talk about it.
Yes. Then nowadays so many young patients are hitting our doors. So as the year goes on, I get more and younger patients, and sometimes that we have 31-year-old mom of two. They struggle to even make to the appointments and then treatments and all these things, and I have to tell her that, hey, have you thought about doing yoga and acupuncture? And you know what I mean? So it's very. First of all, we don't really know a lot of the intervention. We don't really know what the answer is. A lot of times we have these wonderful drugs, but all these great drugs are using very similar medications, and all 90% of the breast cancer targeted therapies are neuropathy induced. So we just cannot stop. But then we want you to live. You know what I mean? But then we want you to actually live. So a lot of times I don't think that we actually do have an answer. So MD Anderson, we have integrative medicine, fatigue clinic, sexual health clinic, and all these things. I'm would you have a time to go to 5 different clinics? I mean, yeah. So it's a reality. It's a big struggle. I would welcome any advice, from you too.
Sometimes something that I've done with some of my patients is when they have a lot of symptoms, we may prioritize one. It's and I ask a question, what it's bothering you the most? Okay, let's start with that. Right? And sometimes you just need to break the cycle. Sometimes you just need to tackle the pain so then you can sleep better. So then in the morning you're less fatigued. And then we can start little by little, step by step. But also, prioritizing that we may need to take one step at a time. So be patient with us.
Yes.
Hi, my name is Jill Canales, and I'm with Memorial Care Cancer Institute and the Pink Journey Foundation. And the question I had was, I chose not to go to the open bar, all-you-can-eat session this morning for exactly the reason the woman said prior. We've been hearing this year after year after year, and I'm just wondering, is there something new? Is there something new this year about alcohol or diet, or is it kind of the same messaging we've been getting the last couple of years, but making sure that we all know and the physicians know that how important that is? So, because I didn't get to attend it, I'm just wondering, was there anything kind of new or novel this year?
I don't think that there was anything groundbreaking. I think it's just, the collective amount of evidence that it's so, robust. now. I think we are learning, in terms of the mechanisms of some of this, like contributing factors. I think there's going to be, for example, data presented at this meeting about the potential use of drugs like, the Ozempic and the Manjaros, like to see how they, right? Like, shall we then treat obesity? So I think there's going to be a lot of that. But in terms of, groundbreaking information, and most of these educational sessions are not necessarily groundbreaking. We will see that at the general sessions. They are just experts summarizing sometimes decades and decades of research. So that's how I will see those sessions. I still learn a lot. Obviously, it's a great summary of the literature.
But if I want to add a little bit of like scientific flavor, because I, would always like to have a hope, is that I think actually there are even some researchers think that just like the GLP-1 agonist has such a global impact in your body that, you know how like we tell you like, yeah, you need to do cardiovascular one day, the next day you have to do isotonic exercise because we think that the metabolism that can really help from the generation of the muscle can really help you. But then like some of us think that actually there might be a secret pill that you don't have to actually exercise, but you can actually take a pill of the final protein and then actually you can have a same impact. So that would be dream come true, right? Like, so there are some hopes. Or, so, like we give you many of breast cancer patients, we make you completely dry, we take you all the estrogen away from you, and then we tell you, go and live your beautiful life. And I know you hate us, you know what I mean? But then at the same time, like my patient was like, oh yeah, when I was getting the testosterone shot, I was really happy. I was very great honeymoon with my husband every day. And so the problem is then all of these things that we can potentially supplement you will come back and bite you from the cancer perspective. But the science has advanced to the point that now we think maybe there's a very specific type of androgen receptor that only lives in the muscle and nowhere else. And so if you could actually develop an agonist that is only go and bind to that muscle and build your muscle, then maybe you have an answer, right? So I think science will maybe give you a new answer, hopefully soon. So there's a hope, I think.
And if I can add to that, basically, I think we are learning more about the safety of these GLP-1s in breast cancer patients. When they started and they became the greatest thing with weight loss, I think we didn't have a lot of data in its safety in patients taking perhaps aromatase inhibitors at the same time, or patients that are, breast cancer survivors and they're perhaps in OFS. So I think what is probably new or what will be new is the fact that we're gaining more experience on how they basically perform in our patients and the safety of them. I don't think there's anything, new per se, but just kind of, feeding into that safety network, I think is going to be a big gain during the conference.
Yeah, I personally have changed my opinion about the GLP-1s. I'm going to say maybe a year and a half, 2 years ago, when my patients were coming, like, oh, I want to be in this drug, I'll be like, no, we don't know, and this and that, and you're going to lose muscle. And, we're learning more about it. But also, maybe I'm starting to, see with different eyes, like the struggle of my patients. And I have patients, and maybe, you identify with this, that through 6 months of chemotherapy, surgery, radiation therapy, they were on it, like the best, attitude, et cetera, et cetera. When 6 months after that, they don't recognize themselves in the mirror because they've gained 30 or 40 pounds because they haven't had, sex with their partners in months, that's when they break in front of me. And they're like, I need to lose this weight. And before maybe I would have been, and now I'm like, yeah, like, let's, get with your PCP and do it. So I've changed my mind in these drugs. And I think that's wonderful about all these conferences, right? That also we as your doctors are evolving our opinions based on knowledge and data.
And I think, the medical community also is going to be more careful. I cannot tell you how many times a PCP reached out to me and say, hey, is it okay if I put this patient on tirzepatide? I'm like, yes. And I think the fear is there because the initial studies for diabetes did not include patients with cancer, but it's growing into me more and more too, to be honest.
Now there's even like a big 2 studies that have been reported for breast cancer patients too. I looked into this because I was teaching fellows in the Vail workshop, and my fellow had this all this ambitious plan in the GLP, and I was like, could there be actually study? And actually there are studies that have been done, and I'm sure more study will come out. And so I think what we think that we know, but actually confirming is actually very important too.
Great.
Yes.
Okay. Carolyn Royce. So I'm a new Alamo scholar, first time at Chavez.
Welcome.
And
Yay.
everything. Yeah. So learning so much, amazing presentations, and I appreciate all the conversation. And I'm going to take it back to your informal statistic about liquid biopsy being a topic a lot of people are still talking about. But, you know, when you mentioned this, and it kind of left off with, currently it's not part of the guidelines, right, for NCCN. It's not endorsed. We don't know how to do it. Or I had my oncologist tell me, well, I don't know what I would do if it went positive, you know. So we don't know a lot still. But in the session today that was on the topic, Pedram Razavi was talking about, I thought, quite a bit of breast cancer data that showing, you know, hey, earlier detection of recurrence can help, you know, switch to another therapy that's more effective. And they had data to support better outcomes, which is what all the insurers are looking for, right, or the guidelines. So how do we change the guidelines if there is data to support it? Does anyone have, maybe, I mean, we're all patient advocates here. How do we take that step? Does anyone?
So I was not at the session, but I'm wondering if they were talking about the SERENA-6, data, study where patients were in a therapy, they were detecting circulating tumor DNA, identifying a mutation, and then doing an earlier switch strategy. So I think what we need is more robust data, longer follow-up to really, prove that strategy, it's really associated with better outcomes for our patients. If what they were talking about was the SERENA-6 study, there are a number of methodological concerns and considerations in the design of the study because they were actually comparing two different treatments with one. So it's again a bit like nuance, and I think once we get the answers that the interventions work, I think you as advocates, but also us as physicians, are going to be the first ones also pushing for the incorporation of this data in the guidelines. Actually, the guidelines, FASCO guidelines, NCCN guidelines, the Advanced Breast Cancer guidelines, we are in those panels, right? So we need your voice, but also we are represented as leaders in the breast cancer community that know the data to really appreciate the evidence and apply it. Because also, we don't want to jump too fast and make things worse, right? Like we need to have the information that it's real, that matters.
I think as a patient, it's such a low impact test, right? And when you have folks that have the non-measurable, don't fit the criteria, how else are you going to measure progression? Scanning may or may not work.
Yeah, so if I may, you can actually do something to make a change is that we are actually, so I'm actively participating in pushing forward the MRD-based intervention study through cooperative groups. And it's very hard to convince the leaders. And then they, different reasons, oh yeah, the current technology may be more sensitive, we can actually wait for a better intervention. But my question is we need to do it now to generate that evidence so tomorrow patients can actually benefit. But I don't even know how many times I had to have a presentations, and the answer is always oh, can you come back with this more data? So one thing you could do is to shake up the our bosses and see if we can actually open a trial so we can actually generate the robust information. So all of us are really struggling to really generate the data in the very limited bandwidth at this time. And of course, in part, that's because the assay is still very important. Expensive. We don't know what to do as an intervention, but if we are able to do the clinical trial, that's how we can generate the data. So help us to open these clinical trials that I've been doing for so many years, and so let's just open it. So help us.
But I think you mentioned something really important. You said the word cooperative group trials. So cooperative group trials are trials that are sponsored by the National Cancer Institute. And many of you, I know that are part of the NCTN network. So these are federally sponsored studies. These are not pharma sponsors. These are academic leaders in the field drive the agenda. based on what patients need. And then you can talk to your legislators. These are funds that come from the National Cancer Institute. So this is federally funded research that has been proven to save lives, that reaches patients in the most remote places in the United States, that reaches patients in rural America, and that we should all continue to advocate for.
Yeah, so if you tell them to open the ctDNA study, maybe our study might be able to finally go through,
And then goes to the NCI, right?
And
NCI.
I think it's a matter of time, to be honest. I think just, I remember the very first time that I heard about a liquid biopsy was in in an NPR, interview in the morning. I was probably finishing internal medicine residency at the time. I was like, wow, this sounds, so futuristic. And that's our reality now. So I think it's just a matter of time. I think we have to be obviously methodic with our methods. Obviously, clinical trial, it's important. There's no way to move forward without clinical trials. But I think it's just a matter of having the right tools, the right data. And I think it's going to be part of what we do.
So you can actually make a difference for us,
Hello, everyone. This has been wonderful so far. And my name is Sheila Pettiford, and I'm an individual member of NBC Alliance and a new advocate, advocate here. This is my first time, but this is my second time coming to SABCS. I don't want to make it about me, but I was very, very impressed with a session you didn't mention, and that was about dormancy. And I know I'm going to get the name of it wrong, but it was dormancy and how the cancer cells become reactivated and become metastatic. I'm metastatic. I've been metastatic for 11 years. And my issue has been about prevention, and that was somewhat of a key in that session. It was talking about the fact that viral infections can be a factor in awakening these dormant cells. And this is information that was so new to me, absolutely new to me. And I've been an advocate for pretty much the whole time I've been metastatic. So what has always been, and I don't know if this is a question, more so a statement, I'm just befuddled about the fact that we don't talk about how you can become metastatic enough. Just now with I'm trying to be sensitive about different things because, like I said, this was a very impactful session to me personally because my metastasis was in my lungs, and they were talking about how it happens in the lungs and it can come from a viral infection. I related to everything that was said in the session. However, I guess my question is, how can clinicians talk more in terms of giving us full information? And I know that's a hard ask, but giving us enough information that we can make certain lifestyle changes, that we can look at all the different things that could cause a reoccurrence and it not be such a surprise. I was completely blown away. It was 10 years and then I had this reoccurrence and I didn't even understand it. And then the language is all about remission, no evidence of disease, no evidence of active disease. There's a lot of questions that I felt could have been answered by my doctors, and they weren't.
Yeah, I'm just going to interject. Thank you. We have 13 minutes, and we have 5 more people in line. So I'm going to ask our panelists to to snap it, make it snappy. No, to share your information. So I would love to get more of the questions answered, but if we can give some.
Yeah, so the viral infection and the lung awakening is actually very new for us as well. So the Nature paper just came out not too long ago, less than a year ago. So many of us are actually starting to understand how this host and the microenvironment tumor actually really triangularly interact with each other. But I think that's actually important for us to even understand that also the environmental factor could really play a role. And many of the clinicians actually don't understand either. Like our medical education is also limited to be able to even inform themselves. And so, of course, that's something that's why we need to just kind of have a conference to have a discussion, like this.
Dr. Canola?
Short answer.
I'm just going to piggyback and say, I think there's a lot of stuff that as a clinician, my patients ask me, and I'm like, we continue to learn. And I'm not going to extend myself. I think, you answered the question, but it's one of those topics that we need to research more. And we went to med school, we went to fellowship, but we still learn every day. Yeah.
Hi, everyone. This has been great. Thank you so much for all of you that are there presenting to us. My name is Ivis Vivas Sampaio. I am the retired Chief Officer of Diversity and Inclusion at Shared Cancer Support. I'm part of the NCI Alliance. I represent the Disrupt Project, and I'm a 32-year breast cancer survivor. So that's where I want to go back to, and I'm trying to make it quick. The Young Women's Session, I was there. I've always been very interested because, believe it or not, one time I was young. As I spoke with Dr. Ann Partridge, I'm part of her committee, she said, no, you're not older, you're a senior young onset breast cancer, so I'll go with that. But the thing is, my point is, I think that we need to come up with an intervention. Build it as a study because it's important to study it, obviously, to prove that it's working. But an intervention because too many young women are being misdiagnosed or diagnosed de novo. And enough is enough because I've been coming to SABC for at least 20 years. And being involved with MBCC, Project Lead, and everything else. And I keep hearing that. And I keep saying, well, why isn't anybody training the OBGYN doctors? Why are we not using the stories of the young survivors, those that were pregnant and came out? I had given birth to my son. I was misdiagnosed for 18 months. I was nursing him, and I wasn't sleeping. So when he kept telling me, oh, no, it's nothing, it's when you're nursing him, I was like, fine. Then when I finally got to really sleep, I was like, oh, no, you're going to put your hands on my breast, and you're going to do a clinical breast exam because you've never done one. And that just started everything moving forward, and that's why I'm an advocate. Instead of getting angry, I wanted change, and I wanted to be able to help other women not go through what I went through. And the point is, we need to be able to study this, and we know that in order for it to get paid and to move it forward. But why don't we come up with that intervention, using our stories, making sure that the OBGYNs, they're right there. They're the ones that usually the woman will go to, whether she's pregnant or not, and say, I'm kind of feeling this, this, and this. And if we educate them, they're at a better position to then say, I think you may need to see a breast surgeon.
I think the complexities of young breast cancer, it's something that is coming our way, and we definitely need to understand it better. But just as I said at the beginning of my introduction, you are educators. Aside from being advocates, you're educators. I remember being in medical school being told that breast cancer or cancer was a disease of the old. That's not the case anymore. It's a disease of the young. So we need to do better educating our physicians, those of us that have the opportunity to have trainees to educate them, because it starts with them. I think the complexities are going to require, many years of research, but we need to start by, advocating and educating.
Wonderful. Wait.
Good evening, ladies. My name is Leonie Span. I am a Alamo Breast Cancer Advocate, first year. I'm also a survivor. And I wanted to talk with you guys really quickly about what we were speaking about earlier with the alternative treatments that can be used to address things like neuropathy and fatigue and things of that nature. My question is, what can we as advocates do to move that needle to the point where there is more whole person care when it comes to cancer survivors? Because we want you to be focused on the science. We want you to be figuring out ways to get rid of this tumor. And if it's going to take more for you to go off and study about acupuncture or yoga or how you eat or anything, we want you to focus on the tumor. It sounds like the evidence is there as to what these treatments or things can do to actually help us handle these side effects more. But as a survivor, and please don't take this the wrong way, to hear you say, please be patient with me, I cringe. Because sometimes these side effects are so severe that our quality of life is just completely shot. And we're doing nothing but dealing with side effects. And if we already know that the science is there, that these things are going to help, then it sounds to me like, can't we put a system in place where instead of you having to address those issues. Once you're made aware of what our concerns are, that there's someone else that can coordinate the care so that they can say, let's look at this. Do we have this available? Let's try this. Instead of us having to come back to you and then wait 2 months again to come back to you, or another 3 months, or whenever that time frame may be. Unfortunately, I've had the opportunity to take advantage of more than one healthcare system. And I will say that when you were talking earlier about a mother having to come and having to deal with her kids and everything else, guess what? I'll take a whole day off. If I come in and I see you, I go get acupuncture, I go get yoga, or whatever else needs to be done, but at least my symptoms are being addressed and I'm not having to sit on them and suffer literally. Because if my mind is constantly at a level where it can't relax, I'm not gonna heal. And so my outcome is never gonna be as good as it is if I can manage these side effects. So what can we as advocates do to work with clinicians, to put systems in place so that there are people that are available for us to speak to, and it offloads you having to handle that when you got 25 patients you're trying to deal with, and this patient may need 45 minutes versus 15. What are your thoughts on that?
So first of all, I did not, intended to be insensitive on the symptoms, saying that. I think it's more, we just don't have the answers all the time. And the interventions are complex, are not as effective as we will want them to be. It takes a lot of trial and error to get the right intervention. And sometimes there's nothing that really makes a dramatic improvement. So that's what I meant. It was in any way meant to be, offensive or dismissive, or the symptoms. It was more, intended to be about a partnership where we care, but we cannot necessarily make the symptoms go that fast. And I think what you point out, it's a real problem of the fragmentation of medical care. I mean, it is true. It is true that I may want one of my patients to be seen by one of my colleagues, and I cannot get an appointment until 3 months later. So I think you are, addressing a fundamental issue that we struggle with, right? How to create more integrated systems that work in parallel to be more efficient and address things in a better way. I think, I don't know the solution. I think it comes from the integration of our own healthcare systems and trying to put the patient in the center.
Is there a push that advocates can do to try and come to the healthcare systems to ask for a better way for that to be managed?
I mean, I think in realistic terms, it really comes down to the money, I think. So for example, none of this navigation system and all these things can really generate the revenue. And I think that's why I don't think that people don't not know, they know, but they just close their eyes and pull the blind side. But that's a whole healthcare system that our healthcare is not a healthcare, it's a disease care. So I think the whole healthcare has to be moved to actual healthcare, and our billionaires know exactly how much of the wine they can drink, and then they're totally fine in the heart rate. You know what I mean? Yeah. So it really comes down to the money, but how can we actually move them? I think that's where all these policies and patient movements can actually make a difference. Okay. And breast cancer patients advocates are the strongest advocates that I know personally. And I know that you guys can make a lot of things happening in the DODs and other things. And so maybe there has to be, rather than the grants or anything, maybe there has to be more strategic implementation of the mandation of breast cancer patient has to have a neuropathy, like this type of regimen in companion with the treatment regimen, or something like that. So.
Agreed. We're going to take, we are at 3 minutes, a little under 3 minutes.
Very fast, I swear. Hi, my name's Annie Bond. I've had metastatic breast cancer for 10 years. I was diagnosed when I was 26 years old. And I feel like I was in the young women thing. And what I noticed is there was a severe lack of talk in any way when they were discussing fertility to include the metastatic community. I know that I didn't even have an oncologist bring up my fertility. It was a nurse. And when I brought it up to the oncologist, he said he'd fire me as a patient because it was too risky. I didn't listen. I froze my eggs anyway. But I have had to have my ovaries removed, which was a wonderful decision for me, greatly improved my quality of life. But I feel like this has been a conversation that we've been closed off to, and there's no other kind of way to put it than people expect us to die before we have to deal with that. But I've been here 10 years. I have a friend over here who's been here over 20 years with this disease. And I'm just wondering, how do we include us more in this conversation? Because it is a quality of life for a lot of us. Like when I was diagnosed, I was like, do I want to have kids? I'm 26. I don't know. Still don't really know. Glad I froze the option. But I just was really struck by the fact that we just weren't even mentioned in that.
But I think in large part, so I had one of my youngest metastatic patients was 20 years old, 20. She was a biology major and she was having back pain for 8 months and she thought her just books were too heavy. And I remember I had to have a conversation about this potentially, whether this is the only opportunity for us to freeze your egg with her father, okay? Like this 20-year-old crying in front of me, and then I had to talk to her dad that, do you want to freeze your daughter's egg? Because I know that 20 years old does not have the money of $6,000 or $20,000 to go to the IVF clinic and freeze your eggs today. So the disability of the barriers of this talking about the fertility is layers and layers and layers. Like not only the life is at stake, but we need to have a fertility physician who are experienced, who will be willing to do it, and then they have to have a time. And then that's $20,000 one IVF cost, So we are not talking about some nuisance things. And that's why I think a lot of physicians are like, okay, let me just save these patients first. So I don't know what the solution is, other than talking to the 20-year-old's dad, I don't know.
Yeah.
Okay, so that's my honest answer.
I had a patient with metastatic disease that got pregnant. That had a child. She had a surrogate, and we had a long conversation about this. It was very hard for me because she had metastatic HER2 positive. She has metastatic HER2 positive breast cancer, inflammatory. And I just was thinking, let's make sure that you are around for the baby that you already have. And I just didn't fit the possibility of stop the treatment. So anyway, we actually at some point stopped the treatment. She was able to regain ovarian function. She got an retrieval, and she had a surrogate. And I learned a lot through that experience. And that baby, it's now not a baby, it's 8 years old. And for them, for their family, it was the right thing. And one day she looked at me and I said, I knew the rest. I already have one son. And if I am gonna die of this disease, I want my son to have a partner in life. And I mean, what am I gonna say to that?
Thank you so much. We are going to have to close the session. What we're going to do is our panelists can probably, if they can, stay for a few minutes and take some of these questions. We have to close the session because it's live streamed. So we'll still stick around, and hopefully our panelists can continue some more of this important questions. I don't want to feel your questions can't be answered. If we can just come up to the stage, and we'll take that offline.
Thank you.
Thank you again, everyone.